Welcome to Healthcare Logic for Growth, the weekly show where we talk life sciences and healthcare in general, things like clinical operations, research, commercial strategy, market analytics, and what it takes for anyone in healthcare to grow in a sustainable way. I'm Eric Marr, your host, the founder of Life Science Logic and a current Life Science Association board member. So whether you're building a biotech, running a rural hospital, leading a home health agency, or shaping healthcare policy, this show is for you. Welcome back to Healthcare Logic for Growth. I'm your host, Eric. I'm the founder of Life Science Logic, and this is the show where we cut through the jargon and clearly talk about what it is that you really have to focus on to grow in life sciences and healthcare. Today, we focus on home healthcare and the changing dynamics they're faced with. The title is Home is the New Site of Care: Why Home-Based Growth Depends on Design, Not Just Demand. Actually, a few months ago, a hospital discharge planner called me with a problem. It wasn't about clinical quality. It was about capacity. Her hospital was full. Patients were medically ready to leave, but there was nowhere safe to send them. The home health agencies in her area weren't bad. They just didn't have the staff to take on any more patients, or at least at that time. So on the surface, this sounds like a staffing problem, but it's really a growth problem in disguise. Let me explain that. Somewhere in that same city, there's a home healthcare company that could have taken those referrals and grown their business. They could have become the hospital go-to partner for years. The only thing stopping them was their operating model. It wasn't designed to actually handle more demand. And here's why that kind of thing matters right now. For many locations, the actual center of care is shifting to the home, and the population continues to get larger and larger, as will this shift. And this is happening for two big reasons at the same time. First, patients want it. It's more comfortable. It helps deal with the issues related to dignity. And frankly, with all the moving pieces in home health care, they just feel settled in. Secondly, the actual system wants it. It's almost always cheaper than a hospital stay. When patients and payers agree, that's not a trend. That's likely to be a permanent change. But here's the tension no one really talks about at conferences or in boardrooms for large home health associations. Wanting to grow in home health care and being built to grow in home health care are two different things. Today, we're going to break down a major myth that limits small home health care companies in any region. We'll talk about what needs to be true in your staffing and service design to handle demands just like this. And we'll look at how to use reimbursement realities to make better decisions, right now, not just someday in the future. So by the end of this episode, you'll probably have a better idea if your company is ready to align with this shift, or if you're just positioned to talk about it at this point. But at least either way, you'll be aware for when the time is right. And if today is, the right time, you'll have some ideas of a go-forward strategy to help you proceed. We frequently talk about, in all of our episodes, the myth or misconception that people are faced with, regardless of the category: life sciences, home health, administrative, whatever the case may be. Today, obviously, we're dealing with home health care. So I hear this belief in almost every conversation I have with home health care owners or people that manage the agency. And it makes perfect sense on the surface. And the actual myth is home-based care is just cheaper, facility-based care. Let me tell you the reality. Home-based care is not facility care in a different location. It's a different business model entirely. And here's why this myth can be very expensive if you're not careful. In a facility, nurses are near each other. One nurse can cover multiple patients because they're all in the same building. In the home, travel time eats up your day. Every single visit has drive time. parking and paperwork in the car, there's no overlap. The math is different. A caregiver who sees 6 patients a day in a clinic might only see 3 in the home. If you plan your growth like a facility, you will always be understaffed and be behind. So let me say that again. A caregiver who sees 6 patients in a day in a clinic might only see half of those in the home. Next, reimbursement is very different as well. Most home health agencies will say that as well. A service that is profitable in a hospital might be reimbursed at a much lower rate in the home, or it might be bundled into a single payment. I've watched companies build beautiful clinical programs, launch them in homes, and only discover later that the payer mix didn't support the visits their protocol required. So what does that mean? Well, you have to design, right? Service design is where it actually gets very real. In a facility, you control the environment. In a home, the environment is whatever the patient has. And what the patient might have is, just being honest, animals, other family members that live there, stairs, a basement, or just in general, no one to help them. So your service design needs to effectively handle this variability. Companies that treat the home like a smaller clinic are surprised by no-shows, safety issues, and readmissions, all of which quietly eat away at their margins. The better mental model is this. Home-based care is a logistics business as much as a clinical commitment. The clinical care is obviously primary and matters very much, but you only get paid if your logistics work, and how much you get paid is equally dependent on how prepared you are. Let me share a real scenario. I was advising a home health owner last quarter, actually a friend who just happened to be own the home health agency. A hospital wanted to send her a steady stream of post-surgical patients that were spread out through the region that the hospital served, a very rural region. Real volume, the kind of relationship most home health agencies dream about. Her instinct was to say yes immediately and figure out staffing later. I respectfully interrupted and asked one question. What's the reimbursement rate for this specific patient population under a specific payer? And does it cover your fully loaded cost per visit, including drive time? Now, she didn't know, most people wouldn't. The excitement of the referral crowds out the math that determines if it's doable. Not only if it's a good deal, but if it's even a deal that can be done. And this isn't unique to her. Almost every company at its growth stage gets this type of offer. And I'm not saying it's bad or to say no to an offer like that. I'm saying be prepared. The ones who succeed are the ones who run the numbers before they say yes, not after they are understaffed and underpaid. So here are some takeaways from today. Today is a little bit shorter episode than we've been having. Number one, home-based care is the growth setting of the next decade, or at least that's what it's looking like. Patient preference and payer economics come together and finally agree. It's going to happen. But it's a logistics business under a clinical umbrella. Staffing ratios from a facility don't translate to a home. Travel time changes everything. There are other things that change it, but we'll talk about that in upcoming episodes. Reimbursement is location specific. A profitable service in a facility can be a money loser in the home. Build and check the rate before you build the program. Number 4, service design must account for the patient's real environment. What happens between visits? Is the home safe? You need to plan for this. Number 5, referral volume is not the same thing as a good deal. Always run the margin math on a new population before you say yes. So as you know, in every episode of our podcast, we close it out with a go-forward strategy versus just identifying some alternative considerations. We actually presume that some of this might make sense to you. And if it does, you can go forward. So we're going to go with our go-forward strategy today. So if it relates to your agency, these are specific actions you can take right now. And here are 5 for this episode. They all kind of overlap, but I'm framing it differently in different ways because I want it to be something you remember and give it a shot. So, number 1, build a drive time adjusted staffing model this week. Take your current caregiver schedule, add actual drive time and documentation time between visits for your 3 busiest routes. See how many daily visits you actually have capacity for. If there's a gap between that and your projections, fix it on a spreadsheet, not during a missed visit. Number 2, pull the reimbursement rate before you expand. Before adding a new service, get the exact per visit or per episode rate from your top 2 pairs. Compare it to your fully loaded cost per visit, including travel. If the math doesn't work now, it won't work at higher volume. You need to fix the rate or the model, not add more patients. Number 3, map your referral sources by payer mix, not just volume. List your top 5 referral sources. Note the primary payer type behind each one. Medicare Advantage often pays differently than traditional Medicare. Knowing this lets you negotiate or prioritize with real information. Again, more information, better decisions, likelihood of profitability goes much farther than not knowing those things, right? Number 4, audit one service line for home environment risk. Pick your highest volume service. Ask, what happens between visits? Who is present? What could go wrong? If you don't currently ask these types of questions, add a simple question to your intake form. This one change can reduce safety events and readmissions that quietly kill your margin. Number 5, say no to one referral relationship until the math works. If you have a referral source whose payer mix doesn't cover your costs, have that conversation this month. Renegotiate the rate, adjust the visit protocol, or pause taking new patients, at least for now. Growth built on unprofitable volume isn't growth. It's just a bigger version of the same problem. By the way, this is kind of new to us, but we're doing it as it relates to home health care. We're looking at building a tool called the Home-Based Care Margin Map, specifically for small agencies evaluating a new service line. It would walk you through the drive time adjusted staffing, reimbursement by payer type, and the 3 questions that predict if a new service will be profitable at scale. If we have enough interest, 10 to 15 home health agency followers or subscribers, we'll take it on and provide it to everyone at no charge. So keep that in mind, and if it would be helpful, please pass the word. So that's our time for today. We obviously provided just a handful of ways to support your agency. There's more to come. We kept this a little bit shorter. We were told that we were making our episodes a bit too long, so this is our first attempt at making it a little bit more palatable and not take up too much of anyone's time. But if you benefited from what you heard, please subscribe or follow us. Thanks again, and take care. Thanks for spending time with me today on Healthcare Logic for Growth. If this episode brought you value, share it with someone in your network who's navigating their own commercial journey. I think they'll appreciate it. And if you have a healthcare-related topic you want me to tackle, leave me a note at eric@lifesciencelogic.com. Thanks again. I hope you'll join me on the next episode.